All right. So this morning for our presentation, we have Dr. Saurabh Khandelwal with us this morning. I think he is no stranger to you all. He is an associate professor in the Department of Surgery. He started his medical career at Rush School of Medicine, then proceeded to Northwestern for a general surgery residency, and then came here for his foregut and advanced laparoscopy fellowship. As with many of our talented faculty, we were fortunate to attract him to stay after training and to become a faculty member who has really brought so much to our department. He holds many titles, many of them I think you are aware of. He is the Associate Program Director of the Department of Surgery, Minimally Invasive and Advanced GI Foregut Fellowship. He is an Associate Program Director for the General Surgery Residency Program and the Site Director at Montlake. He is a core faculty member as part of WISH and has really done quite a bit of research in bariatrics, both in kind of longitudinal studies for surgery and obesity pathogenesis. He is also known as a master educator, both through his extensive work in SAGES, but also here locally, having been recognized for many roles that he has played both in undergraduate medicine, the GME, the Department of Surgery, and also the residents recognizing him with the John K. Stevenson Teaching Award. So Dr. Khandelwal, thank you for joining us this morning and advancing our understanding of bariatric surgery looking forward.
Good morning, everyone. Thank you, Dr. Marquardt, for that introduction. Thank you, Dr. Wood, for the opportunity to speak today at UW's first Grand Rounds for 2024. I'll be giving a talk today about metabolic surgery, or what used to be called bariatric surgery, and discussing its past, present, and where it's going in the future. The overview for today, as I said, we'll be reviewing the scope of the problem of obesity. We're going to go over current operations and therapies, and also give you a historical perspective about how we got to these operations. We'll also be talking about future directions of both medical and procedural and surgical therapies as well. I have no disclosures for this talk. So, as you all know, we've made it through one pandemic, and a lot of people, however, believe that obesity is truly the largest worldwide pandemic of our time. And I never cease to be shocked at the incidence and obesity trends in the United States. And I'm going to take you through them and go decade by decade. This is what obesity looked like in the United States back in 1990. And as we advance per decade, you see that the entire nation, up till 2020, with the exception of Colorado, had an incidence of at least 25%. And in 2022, that also fell. And all states now have a prevalence of at least 25% obesity, which again is defined as BMI of greater than or equal to 30. These are some sobering statistics. It affects all age groups. It affects all races. Adolescents now, between the ages of 12 and 19, 22% obese. Overall obesity prevalence in adults, nearly 42%. This disproportionately affects Black and Hispanics, with rates approaching 50%, and non-Hispanic Asian adults have the lowest rate. They, however, unfortunately incur the equivalent metabolic risk of Caucasians at a significantly lower BMI, and we'll discuss how some guidelines have changed in the treatment of obesity in their population. Pre-pregnancy obesity is also significantly increased. This is associated with increased complications both for the fetus and the mother as well. It's estimated that medical costs related to treating obesity in the United States are at least $170 billion. This is based upon the most recent analysis using 2019 dollars. And the average annual medical cost for an adult with obesity is approximately $1,800 higher annually. As you all know, because we all take care of patients who have comorbidities, obesity is something that significantly increases the risk for multiple major illnesses. These include things such as heart attacks, heart disease, stroke, type 2 diabetes, multiple cancers, and a lot of these are causes of preventable premature death. Many of our faculty in this room work in the arena of cancer, and at least 13 malignancies are associated with being overweight or obese, as shown in that diagram in the upper right over there. Down below are some statistics about prediabetes, and prediabetes very carefully correlates with the level of obesity in the United States. There's nearly 100 million adults in this country who are pre-diabetic, and all are at significant risk for these metabolic complications should they not do something about their weight. Besides those fairly significant medical problems, if you look head to toe, really every organ system is affected with obesity or by obesity. And this really adds up to a tremendous burden of disease. And it's a relatively new disease in human history, really being quite rare before the latter half of the 20th century, but progressing rapidly in the 1970s starting, and then in the 80s and 90s, as I showed on those previous slides. However, obesity is not something entirely new. Neither are weight loss procedures. This is the first historical documented weight loss procedure done over 1,000 years ago in Spain. King Sancho I of Leon was apparently too large to ride his horse or wield his sword, and he actually lost his throne. He was sent to a physician at that time who sutured his lips shut, and he drank liquids through a straw for 40 days, and it worked. He lost weight, he rode back home on a horse, and regained his throne. We actually know this works because we don't do something that's terribly different when we prepare people for bariatric surgery. We essentially put them on a liquid diet for about 3 weeks, and they'll tend to lose easily 15 to 25 pounds. 1,000 years passes until the next weight loss operation is described. And that was done in 1954 by Kremen, who described the jejunal-ileal bypass. Various bypasses involving different segments of the intestine and colon were done in the past, and all of them resulted in significant weight loss, but also significant malnutrition and complications. And we really get to 1966, where the first gastric bypass is described by Mason. It was different from how we perform it today, but that was done to address some of those complications. And over the decades, multiple operations, some of which you all have seen or heard of, or perhaps taken care of patients who've had them, progress. And I'll briefly go through some of the ones which really form the canon of bariatric surgery. So we talked about Mason describing the bypass in 1966. Scopinaro in 1979 performed the first biliopancreatic diversion. Mason again in 1982 performed the VBG, or the vertical banded gastroplasty. And let me see if my mouse is working. There we go. In 1988, Hess and Marceau added a sleeve gastrectomy to the biliopancreatic diversion and came up with a BPD-DS. And one of the seminal events in our surgical history was in 1993, where Alan Whitgrove performed the first laparoscopic Roux-en-Y gastric bypass, which really ushered in the modern era of bariatric surgery. In Europe, in 1993, the gastric band was first done in Belgium, and it was approved by the FDA here in 2001, where it rapidly took off in popularity. The sleeve gastrectomy, which is the most common operation done today, was first described in 2007, and it was a bit of a serendipity event in the sense that it was actually used as stage one of a two-stage procedure to either perform a gastric bypass or BPD-DS. In people who were too obese to undergo anesthesia or the operation safely, the sleeve was done first, and after they lost weight, the patient would return for the second stage of that procedure. The observation that these patients were losing enough weight with that first stage led to the concept that perhaps this ought to be used as a primary weight loss procedure. And indeed, after that happened, it took off very rapidly about 10 years later, now becoming the most commonly done procedure. These operations broadly fall into two categories, restrictive and malabsorptive. And here are a couple of diagrams of some historical restrictive operations. And the adjustable gastric band, which is more commonly known as a lap band, is the one on the bottom right. And although that is still performed, it is rarely done. It really has rapidly fallen out of favor due to suboptimal outcomes, which include poor weight loss, high reoperation rates, and significant rates of reflux and regurgitation. Malabsorptive operations, which are again shown here with the currently performed ones done in color, all feature anastomoses with the exception of the sleeve. They typically are both restrictive and malabsorptive. The sleeve, although it has no anastomosis, still affects absorption through hormonal changes, which we'll talk about a little bit later in this talk. A lot of these operations, as I said, work through restriction and or malabsorption. And with that come nutritional deficiencies. A lot of these will help people lose sustained amounts of weight, but some will suffer from some of these significant complications, which I'm sure many of the residents in this room have managed as patients get readmitted and taken care of. We've also seen patients with some of those legacy operations come through here. And a lot of these issues are very prevalent in that population. Restrictive procedures, such as the band, tend to not have as many of these problems. However, those patients typically suffer from significant elements of reflux, dysphagia, esophagitis, Barrett's esophagus. They also tend to have suboptimal weight loss. This diagram on the right side of the screen outlines typically where things are absorbed in the human gut. And if you understand what got cut out or what got bypassed, the expected nutritional deficiencies to look out for, and also the guidelines as to what you supplement tend to start to make more sense. Besides just the amount of intestine bypassed or what parts altered gut flora also clearly seems to play a role here in how things are absorbed properly or not. So what are the big themes here? What are we doing with all these operations? We can reduce the size of the stomach. We can bypass some length of the gut, which essentially means we're separating the flow of nutrients from enzymes, which would be digesting and leading to absorption. We can restrict how much someone can take in with bands, with mesh, with staple lines. And we can also combine these approaches, which has been done in various ways. We can also modify them to try to reduce complications. And this is where you see all these variations on a theme, such as you might hear things like the omega loop bypass, single anastomosis bypass. They're all essentially trying to do the same thing, but take out a component which is typically associated with complication. And we do this, meaning these operations as well as procedures, roughly about 250,000 times in a typical year. This data shows the number and types of bariatric operations performed over the last decade. The pandemic showed a small blip, as you see down there in 2020, and that significantly affected us here at UW as well. But most recent estimates suggest that in 2022 to 23, the numbers are similar, roughly around 250,000 total procedures performed. And if you see that graph and look at the numbers, you see over the course of the last decade, the sleeve gastrectomy went from being a very infrequently performed operation to now by far the most common operation performed. And if you combine the numbers of the sleeve and the bypass, they represent roughly 80% of all procedures performed. When we add in revisions, which is someone who's had a prior operation and either for metabolic reasons or complications is being revised to another surgery, those revisions tend to be toward a sleeve, but more often a bypass. And if you add those in, sleeve and bypass really comprise 91% of all operations done. So these two operations really have dominated the field. And multiple studies, including randomized controlled trials, confirm good outcomes, safety, efficacy, and tolerability, as well as sustained weight loss. And I'll briefly take you through the technique with both surgeries. This is a sleeve gastrectomy, and it's a fairly efficient operation. We ligate the greater curved vessels starting at a point about 4 to 6 centimeters from the pylorus all the way up to the angle of His. We place a 40 French bougie down on the lesser curve and perform a stapled resection, which ensures complete removal of the fundus. Care is taken not to narrow at the incisura and create a uniform sleeve to avoid complications such as dysphagia and reflux. And this will typically result in an 80 to 90% reduction in gastric volume. And the part of the stomach that's being removed also matters as well. As you remove the majority of the body in the fundus, the capacitance or stretchy function of the stomach is essentially eliminated. So that's what produces restriction. And ghrelin, which is an orexigenic hormone or a hormone that promotes hunger, we see significant drops in those levels after fundic resection. So as I said, a fairly efficient operation. It's only about an hour to an hour and 15 minutes long and involves no anastomoses. And for many of these reasons, patients are attracted to this operation, but so are surgeons. The Roux-en-Y is a very different operation. And the way that is performed is a 30 to 50 cc pouch is created at the very top of the stomach. And this is done with staplers and it's divided. So again, in distinction to non-dividing staplers, which is how this operation was done in the past at times. The colon is lifted, the small bowel is marched down about 50 to 70 centimeters from the ligament detritus and divided. The proximal portion of that bowel is referred to as the biliopancreatic duodenal limb or the BPD limb. And the distal portion eventually will turn into the roux limb and then the common channel. From that initial point of small intestinal division, a 100 centimeter roux limb is measured typically from that spot, at which point a side-to-side anastomosis is done, which is the jejunojejunectomy. The tip of that portion of that intestine at the initial division point is now brought up near the hiatus and anastomosed to the gastric pouch, which is the gastrojejunectomy. The internal hernia spaces are closed, and that's how that operation is completed. This is typically anywhere from a 2 to 3.5 hour long operation, depending on prior surgeries, patient size, and anatomy, and it involves 2 anastomoses. There are multiple variations on this theme. You can do this operation in an anticolic or retrocolic fashion. The gastrojejunectomy can be performed one of 3 ways, and limb lengths vary depending on different programs and surgeons. The outcomes are typically uniform regardless of the technique used to do this operation though. And because this operation's been along for quite some time, again, nearly 3 decades in its laparoscopic form, and it has excellent outcomes, it's really considered the gold standard against which other operations are most frequently compared. And it's no surprise why. There are some pretty amazing outcomes associated with this operation. This is a reliable solution for a lot of those medical problems that I showed on a previous slide. This is a study that looked at nearly 8,000 patients in both arms, both who underwent Roux-en-Y gastric bypass and those who didn't, were matched for age, sex, BMI, and rates and causes of death were determined from the National Death Index with almost 7-year mean follow-up. For the surgery group, those who had gastric bypass, what was seen was all-cause mortality decreased by 40%, 56% reduction in cardiovascular-related deaths, over 90% reduction in diabetes-related deaths, and a 60% reduction in cancer-related deaths. So quite remarkable outcomes associated with these operations. As I mentioned, there's no shortage of evidence which supports these operations. And as I just showed you the sleeve and the bypass, although they're very different in how they're performed, there are a lot of similarities. And some of those similarities include the majority of their outcomes. If you look at multiple studies, the remission rates for type 2 diabetes, sleep apnea, hypertension, dyslipidemia are fairly similar, although some studies tend to favor Roux-en-Y for diabetes remission. And to be clear, remission means cure. A remission rate is typically seen between 25 and 30% for these operations. However, the rate of improvement in diabetes tends to be at 80% or higher. And frequently, what that means is someone who's able to de-escalate their therapy, someone who was previously on insulin who goes to control with just medication or diet is an example of that. Other outcomes of note and difference. Sleep patients tend to have more GERD and esophagitis, whereas this is essentially in remission in over 90% of patients with a Roux-en-Y due to the fact that a very small proximal pouch is separated from the rest of the stomach. Weight loss tends to be, is shown to be higher in some trials after Roux-en-Y. In some trials that is not statistically significant, but both weight loss in both operations, weight loss is sustained at least in 10 years and significantly beyond for Roux-en-Y. The Swedish obesity subjects trial has followed patients who've had Roux-en-Y for over 3 decades, and even at 3 decades, typical weight loss that is maintained is around 30 to 31%. Both operations do have a reoperation rate, as would be expected. That tends to be higher with a Roux-en-Y, and that's essentially related to the higher complexity of that operation. You are doing 2 anastomoses, you are rerouting and rearranging intestine and stomach, and sometimes those things develop problems. Mortality rates for either operation range between 0.1 to 0.5%, depending on the study that you read. And as I mentioned, there's no lack of evidence supporting these, with over 20 randomized controlled trials, which have shown and demonstrated efficacy and safety with these procedures, as well as with successful improvement, if not remission, of common metabolic syndrome or obesity-related diseases, which are often the primary endpoints for these studies. So as I say, if it isn't broke, should we try to fix it or improve it? If we look at the current iteration of the gastric bypass, it really hasn't changed much in about 30 years. And the sleeve is essentially as described, with some minor modifications, for almost 15 years. These are reliable operations. They have a proven track record of safety, predictable results, and broad acceptance as the gold standard for helping patients achieve durable, sustained weight loss. And long-term results persist, but require maintenance, which is why patients should be working with a program that can offer longitudinal care. So as I said, these things seem to work pretty well. Should we be thinking about changing them or going in a different avenue? One has to remember that all of these operations are invasive. They are essentially irreversible. They tend to have high upfront cost. They require general anesthesia, and there are also many exclusion criteria for these surgeries. They can have early and late complications, some which can be life-threatening, and they really require a lifetime commitment to eating a certain way, taking supplements, routine blood work, follow-up, frequent imaging studies or endoscopies to either diagnose or treat problems. So is there something better? Is there something less invasive, perhaps removable or reversible, with less risk, easier, less costly, good results? How do we get from old and reliable to something newer and more fancy? Well, if you asked me 5 to 6 years ago, I would have told you endoscopic bariatric therapies might be where we were heading. And these include a lot of devices which you see on this slide, such as space-occupying balloons, endoluminal barriers to reduce nutrient absorption and contact. Endoscopic sleeve is also a procedure that was created. That device on the screen left is called the Aspire Assist device, which essentially is putting a peg tube in. You go and eat food, and then you go to a discrete location and essentially empty what you just ate from your stomach. That did not take off well, mostly due to the fact that people don't like G-tubes, and there are probably some social issues associated with having a permanent one in. Magnetic anastomoses have been described to create intestinal bypass anatomy. And a lot of these showed initial promise, showing weight loss of between 3 and 20%. And the promise for many of these procedures were they were reversible, they were removable, they could be done at a lower BMI criteria, they had less initial expense, and they could be done in an outpatient setting, often simply with sedation. That really hasn't turned out to be the case, though. And what we have found with a lot of these have been high device failure rates. Many have a finite duration of therapy, and they must be removed. If you get an Orbera balloon, they take your credit card, and if you don't show up at 6 months to have it removed, they start charging you. It's their way of, I guess, instead of a carrot, using a stick to make sure it gets taken out. There are little to no insurance coverage for these therapies, and they tend to show poor durability and don't have a lot of data suggesting efficacy beyond a year to 2 years. So as I mentioned, it really didn't turn out how we thought things were going to. And right now, endoscopic therapies are less than 2% of weight loss procedures performed. So what changed? How did our direction and our thinking change or evolve? Was it the pandemic? Was it cost? Was it coverage? Where did we go instead? And to understand that, some historical perspective helps, as it gives you an idea of kind of where our field has gone and where it is today and where it's going. So some important times and events in our metabolic surgery field are as follows. So in 1991, over 30 years ago, the NIH published the first consensus guidelines, which really gave the criteria which were used to offer someone or not offer surgery. In 1997, a couple years after that, the American Society of Bariatric Surgery was founded to support obesity research and awareness, and they published their consensus guidelines a few years later. In 2006, CMS announced a national coverage policy for bariatric surgery, and this allowed patients with Medicare and Medicaid to have access to these procedures, which was quite important. In 2007, an international diabetes summit, which that time held in Rome, endorsed Roux-en-Y gastric bypass as a treatment for type 2 diabetes. That was the first time a surgical procedure had made it onto the algorithm for treatment of the metabolic disease. And in a short time, the ASBS changed its name to ASMBS to really reflect growing evidence that bariatric surgery can treat metabolic diseases. The ASMBS and the American College combined and formed a unified national accreditation program in 2012. And importantly here, in 2013, the AMA recognized obesity as a disease. And that's actually important for several reasons. So with the recognition that this was a chronic progressive disease, this opened up streams of funding, research, and coordination and care, and the ability to establish coordinated guidelines between many of these organizations, as they often have diseases that overlap one another. And this certainly also helped in the coverage of operations and therapies, as this is now recognized as a disease. And we really started understanding obesity and viewing obesity as a disorder of homeostatic mechanisms. The body tends to fight change, but with the set point in obesity or overweight is altered to a disease state, it tends to go higher in weight, and the body resists people getting back down to normal weight. And this obesity statement made by the National Endocrine Society back in 2017, I think summed it up best, where it said obesity is a disorder of energy homeostasis characterized by defense of an elevated level of body fat mass. You see in this graphic several of the back and forth factors which go into determining weight, and they also help us think about where are the areas that we can intervene and provide therapies. As I mentioned, as this became thought of as a disease, the mechanisms started to become better and more elucidated. The adipoinsular and enteroinsular axes became more prominent in our understanding of energy and food metabolism. Their dysregulation obviously being one of the causes of obesity and disease. And as these operations were performed, as diabetes was treated with some of those newer medications, observations of postoperative effects in anti-diabetic therapies led to several observations. One is that these operations, especially the sleeve, reduce ghrelin, which modulates dopaminergic reward pathways and promotes hunger. We see upregulation of satiety hormones such as GLP-1, polypeptide YY, and neurotensin, which tend to lead to anorexia and delayed gastric emptying. Several MRI studies have shown that with metabolic surgery, as one starts getting back to a more normal weight, taste, meal size aversion, reduced hunger all set in. There tends to be what's called neuroplastic structural recovery with restoration of functional connectivity and normalization of the brain response to food. And the more one looks, the more complex it gets. There's as much neuroscience here as anything else, and the gut-brain axis really becomes the focus. Genetic predispositions, biology, and a frequently unfavorable physical and food environment all play a role, and the output of these pathways is behavior. And if you really think about what we've been telling patients for decades, which was just go diet and exercise, or just spend more calories than you consume, it really becomes evident that this is an antiquated way of thinking about this, but it's still very prevalent advice given to patients. So this major shift as these pathways are being elucidated is towards what we call nutrient-stimulated hormone receptor therapies. And as hormonal function and understanding becomes more refined and their role becomes more clear, as we start to understand energy and weight metabolism better, the thinking really shifts to let's mimic endogenous gut hormone function in the normal state. Let's mimic nature. And GLP-1 is probably the most famous of those naturally occurring gut hormones. It's first discovered in 1980. Fun fact, the long-lasting version was isolated from Gila monsters, which is where exenatide, which is the long-lasting version of this drug, comes from. And in 2010, liraglutide was created, which is GLP-1 attached to a ligand in an injectable form. This is a naturally secreted substance created in several areas: the L cells in the distal small bowel, alpha cells in the pancreas, as well as the CMS, and as well as in the CNS. And its major response is to increase insulin sensitivity, inhibit gastric motility. And this is in fact how it works. But GLP-1 is kind of the tip of the iceberg. This is a very busy slide, but it shows how many gut hormones there are. And we're starting to, as we go through the science, learn more and more, but nearly all of them are prosatiety hormones, and they inhibit GI motility. Notably, with that red arrow, ghrelin is so far the only orexigenic or pro-hunger hormone that we have isolated. And that represents a target for antagonist therapy. And as I mentioned earlier, reduction in ghrelin is exactly what is seen in a sleeve gastrectomy after the fundus is resected, which is one of the areas of where it is secreted. So the thought was, can we package what we see in surgery, the hormonal changes, in a pill? And we're starting to do exactly that. If you look at this slide, the first three boxes show kind of a rubric of single target, double target, and triple target therapy to achieve improved metabolic and weight outcomes. And we thought, well, that's going to be the future. And I remember saying this when I started doing this about 13, 14 years ago. At some point, they're going to be able to recreate a gastric bypass in a pill. And the future may be here. Single, double, and triple receptor agonist therapy is where this field is heading, where the research is heading right now. And as you can see, we're only getting started here in terms of trials that have been completed. In the upper left side of this screen, you see current medications, which include the GLP-1 agonists, as I mentioned. Tirzepatide was just added in November of 2023, but really it's the tip of the iceberg as you look at where the research and these studies are going. So if we look at kind of the older set of medications and we look at these newer medications, which are now becoming available, you start to wonder, well, who gets access to these? And that's a complicated question. As these older drugs are being supplanted by new drugs, which are often very expensive and still not recouping their R&D costs, many insurance companies are requiring the use of first and second line agents and failure of those therapies before they'll approve a GLP-1 agonist, for instance, and typically require diagnoses associated with a metabolic condition such as diabetes or prediabetes. But it is everywhere. It's in the New York Times, it's in Time Magazine. Oprah is on one of these, and a lot of celebrities are using it to promote weight loss. You guys might have even heard of something called Ozempic Face or Ozempic Body, which is making the rounds on TV. In the past 1 year, I just did a search the other day. The New York Times alone had 150 articles or letters referencing Ozempic. It's really kind of the first time a weight loss medication has kind of made its way into the popular zeitgeist. And with the pandemic and with other issues, this has actually led to supply chain issues, which has led to patients either only getting intermittent therapy or having to stop therapy. It's also led to the counterfeit production or adulterated production of these drugs, where you can find a lot of pharmacies that are willing to compound them without having quality assurance. And why is everyone talking about it and so desperate to get it? It's because it works. How well do they work? Well, if you look at the various studies which have looked at GLP-1 agonist therapy, many of which are listed here, the mean weight loss compared to placebo ranges between 8 and 20%. That may not sound like a lot, but when you put that in context of what operations do, the sleeve gastrectomy is typically associated with 20 to 25% weight loss. So we're having medical therapies which are kind of knocking on the door of what an operation can do. The duration of these therapies and these studies lasted up to 72 weeks, and weight loss regresses when the hormones are stopped, which is not surprising. What's coming down the road, and I should mention, so far these are all injectables, so that is another sometimes dissatisfier for patients. But coming down the road is likely orally available GLP-1 agonists, which should be released soon, and likely the first dual therapy drug, which is going to be a GLP-1 agonist combined with a GIP agonist as well. There are, however, as I mentioned, significant barriers to access to getting these drugs. They work, but at best, it's difficult to get them. There are significant lack of coverage issues or exclusions in many healthcare policies. These policies to be approved, or I should say, these approvals require diabetes often as a diagnosis because that's where these drugs came from. They're initially diabetic drugs. And as I mentioned, typically failure of first-in-line weight loss therapies before one can try these. There are high copays. Monthly out-of-pocket costs, even for people who have some insurance coverage, are often as high as between $1,000 to $1,500 a month. And realistically, this needs to get down to at least below $100 before this is something that can be more widely used. And it's an interesting paradigm shift in the thinking of insurance companies. So whereas the upfront cost to surgery was frequently a barrier for insurance companies to either not offer it or to require additional coverage, they've now realized that the patient population that could benefit from a GLP-1 agonist, which essentially is probably 100 million pre-diabetics, this is obviously causing them a little bit of heartburn. So they have really started to put on the barriers to getting these therapies. And it's actually causing some people to steer their therapy choices back to surgery, not because of choice, but because, hey, that's all that I have in terms of coverage, which is not something that we used to hear a lot of, or we actually wish we heard more of in the past. These drugs are not perfect. As I mentioned, they're hard to get, but they also have significant side effects. About half of patients will suffer from one of these conditions. The bigger concerns being tachyphylaxis or loss of efficacy as the body acclimates, but also in some studies, 40 to 50% of patients show antibody formation or immune hypersensitivity to these drugs as they are peptides. And these side effects can be significant. They will cause some patients to stop therapy. Some of these side effects will fade with time, but really what we don't know is how important or how long or how significant are these side effects, and are there more? We don't have any long or midterm study data which tells us what's going to happen to patients taking these drugs. The question comes then, are these forever drugs? Meaning, if you want to maintain the health benefit that you've achieved with them, is this something you're going to have to be on for the rest of your life? And right now, most people think that the answer is probably yes. But although they're not perfect, they really fill in an important gap. So if you look at kind of the three main buckets of how we've had patients approach weight loss, which include lifestyle changes including intensive lifestyle interventions, pharmacotherapy, and bariatric surgery. Previously, there was a fairly significant gap between lifestyle and pharmacy lumped together with surgery, either achieved, up to 9% weight loss, but usually not, or you went down the surgical route to get above 25% weight loss. And with these drugs offering 8 to 20% weight loss, I'm going to show you in a couple of slides how this fits an important gap for a lot of patients who need to lose some weight, but not a lot of weight. So the question becomes, well, which one is better? And, that's not a straight yes or no question. All have pros and cons. And most of them are fairly obvious. If you're looking at surgery, we know that achieves significant sustained weight loss. Surgery right now is the only cure for diabetes. Remember, medications treat it, but surgery, there's an opportunity for remission. You will often improve multiple comorbidities with an operation, as well as reduce risk. And an operation, although it has high upfront cost, may have reduced long-term healthcare utilization. But obviously that comes at a cost. There's permanent alteration of the GI tract, as well as its anatomy and physiology, lifelong need for supplementation. There are surgical complications that can occur, as well as metabolic complications. and the upfront cost tends to be higher compared to other therapies. With medical therapies, it's essentially the reverse, maybe with the exception of the financials. There are multiple options for medications and lifestyle interventions. The GI tract is left intact. This is also a rapidly evolving landscape. What we have today is not what we had even a year ago, and certainly won't be as the future develops and these drugs develop rapidly. The side effects, although a lot of people have them, will often stop if you stop taking the drug. And part of the point is you can stop, right? If it's not suiting you, you can actually stop. And that's not something you can do with surgery, which is essentially a permanent thing once it's performed. Medications like surgery, though, do require compliance to diet. They still require the same kind of social and nutritional support that surgical patients need. This is not just a here's a pill, or here's an injection, take it once a week, see you later. One area that medications tend to be not as good as they tend not to improve other comorbid conditions associated with obesity, which improve from some of these surgical procedures. With the recent cost estimates of these drugs, the long-term costs could be higher. It certainly would be estimated to be that in today's cost in dollars. However, typically we do see drug costs diminish as more and more competitors enter the market and as the drugs stay on the market longer. But putting it all together, really what this class of drugs has helped us with is we now just have more options in making these recommendations. And how do we make a recommendation? We take a lot of things into consideration. What are the patient's preferences? What is the timeline to desired or required weight loss? You can imagine someone who needs a lung transplant does not have 5 years to try to lose weight. There are patient factors, there are contraindications, clinician recommendations, the presence of various comorbidities, and you put all of these together to come up with an effective weight management strategy. And they all need to be taken into consideration. The unfortunate part of this is sometimes insurance coverage can dictate which choices we offer. And at the Weight Loss Center here, we do our best to actually understand that before we see a patient. It's very difficult to say, I've got this shiny new thing, which I want you to try, and then find out that they don't have coverage for it. So we try to understand that before we come up with a weight loss strategy. Here are a couple of scenarios which kind of demonstrate that gap that these new drugs have filled, however. The first one is actually quite common. Someone who needs to lose 25 pounds to get a joint replaced or get their abdominal wall hernia fixed. And medications are ideal for this, especially these new drugs, which will help you lose over 10% of your weight. You don't need, one might say that surgery is just too much if someone's trying to lose 25 pounds. On the other hand, you might have a patient who needs to lose over 50 pounds to meet transplant eligibility. In that situation, medications and workup for surgery would both be appropriate. This concurrent therapy, while you're giving medications as they're going through the process of being worked up, tends to be a winning strategy for many people. The typical workup for surgery can take up to 4 to 6 months, especially for complex patients. Another situation here is a patient recently diagnosed with prediabetes who either does not want surgery or can't get it because of insurance coverage. And this GLP-1 agonist is a perfect drug for that patient. It's designed to address that disease state and also is going to help people lead hopefully between 10 and 20% weight loss. 2 of these 3 patients, meaning the top patient and the bottom patient, might not have had these effective options even a few years ago. We would frequently see people, and if they either didn't want or we did not recommend surgery, the recommendation was we recommend medically supervised weight loss. Please work with your primary care doctor on that. And that rarely ever led to significant or sustained weight loss. The one thing you've not heard me mention is, what about newer surgical options? We've spent some time talking about what are really the current gold standards in surgical therapy, as well as these new medications. And the fact is, there are really not a lot of new surgical options being widely adopted at this time. The sleeve and the bypass really still reign supreme right now in terms of safety, efficacy, and reproducibility. There are some refinement in patient selection, such as picking the right operation for the right patient with some of these physiologic or metabolic conditions. You see some of these other operations like a single anastomosis duodenal bypass or a VPDDS being done in very specific sites, but they represent less than 1% of these operations performed. They're effective. They offer some incremental improvement in some outcomes, such as diabetes, but This tends to be at the expense of higher complication rates and nutritional and metabolic deficiencies. Robotic surgery, although it has taken off in the field of bariatrics with some data suggesting that nearly half of bariatric operations are about to be done with a robot. There, as with many things related to the robot, there's no significant data behind that which shows a benefit over standard laparoscopy, even in anastomotic cases, which is one of the touted benefits of the robot. So really, the two main operations, the sleeve and the bypass, have not changed in at least 15 to 30 years, respectively. But what has changed is the science is starting to catch up. Those operations worked. We now are starting to understand how they work at the cellular and hormonal receptor level. And that has really led to this explosion in pharmacotherapy with nutrient-stimulated hormone receptors. So how will surgery and medications coexist? This talk that I'm giving right now might be presenting this to you as two competing interests. And in fact, they're not. This is really probably going to be just like cancer therapy, where people and therapies work together. What do we do in cancer therapy, right? We look and use different modalities at different times, whether it's chemotherapy, radiation, or surgery, to treat a disease and keep it in remission. And obesity is the same. Medications and surgery, I think, are going to converge. And we're already doing this. We use these medications in the preoperative setting to help reduce the risk of perioperative complications, increase surgical safety and feasibility, and also to maximize and maintain postoperative weight loss. We can use these medications to address weight regain or the recurrence of metabolic disease after improvement or remission with surgery. And the heterogeneous response to obesity treatments really suggests that there is no one-size-fits-all approach. So it's going to be different things for different people based upon not only what suits their needs, but what they respond to. So as I mentioned, I showed this earlier about that timeline of important events in the field of metabolic surgery. And as the field continued to mature and as the evidence grew about the need to intervene earlier and at a lower BMI, the NIH finally responded in 2022 by updating its consensus criteria. So 30 years passed after which those criteria finally got updated. And these are the major updates, the old on the left, the new on the right. The old indicated indications for surgery being a BMI above 40 as an independent criteria, or 35 and higher with an associated comorbidity and an appropriately selected adult. The new criteria stipulate BMI has been lowered to 35 without any related comorbidity needing to be present. BMI is between 30 and up to 35 with metabolic disease. So this is a type 2 diabetic patient with a BMI of 32. Asians with a BMI of 27 and a half. There are times like after I come back from vacation where I'm probably at a BMI of 27 and a half. I never thought that I should be someone who ought to be thinking about having a metabolic operation. The other important area where these guidelines suggest the role of therapy is in appropriately selected children and adolescents as well. So the question that we've contemplated, Dr. Chen and I, is, are we still going to have jobs? You know, are these new therapies going to eventually make us obsolete? And for the foreseeable future, I think the answer is definitely yes. These therapies are complementary. Comprehensive centers such as ours are able to offer patients the full spectrum of treatment options, and really treatment should be personalized. And that's one way to approach this in the right way. We're still a long way off from having any data to change direction significantly away from the operating room. And even the endocrinologists will agree with that. You know, their most recent consensus statement recommends surgery for those categories that I just showed based upon new criteria. The things to remember of what surgery can achieve that medications cannot are a lot of those checkpoints in the bottom half of this slide. We can actually have diabetes be cured in some people with an operation. You cannot do that with a medication yet. You see more long-term sustained improvements in blood glucose handling, reduction in microvascular complications, reduction in CVD risk factors, lower maternal metabolic complication rates, decreased cancer risks, and the ability to resolve a lot of other comorbid conditions, as well as strong evidence that these operations lower all-cause mortality. I'm not saying that some of these won't be achieved with medications, but we just don't have that data yet. And really, this, for us, is an exciting time in our field. Our current operations are highly effective and safe. Significant advancements in nutrient-stimulated hormone receptor therapies are on the horizon. As I showed you, some are already available, likely to be complementary with the world of surgery. This may give us an opportunity to surpass existing weight loss and disease improvement capability. We've typically seen that the body tends not to lose more than a third of its total weight in the best and longest term studies. And this may be an opportunity to push that for some patients. Access will be of utmost importance as this disease disproportionately affects minorities and low-income patients. But I think for the foreseeable future, our jobs are safe and the future looks bright for us. So thank you very much. I'm happy to take any questions. Dr. White.
Oh, yeah. Hi. So thanks so much for an excellent overview. I want to, I have two questions. Number one, complicated, morbidity of these reflux patient who, has had a seed that's been outside institution and whether